All right, so today I'm happy and I'm really honored to be part of this series here. So thank you very much for inviting me. And our topic today will be clinical neuropsychology and motor cognitive performance. And I'll tell you a little bit about how we go about our research. So what we use is a translational approach from experimental psychology to neurorehabilitation. But the question is how we get from the university to the clinical settings, actually. And let me first explain you how we do this. So our research includes basic experimental approaches as well as the development of standardized performance assessments and trainings. In our group, the general research concept is translational, so developments in one field here ideally inform and push the others in a translational manner. In the next step, we then test and implement our approaches in clinical settings, and oftentimes then still some adaptation is still necessary before the final approaches can be transferred and put into action. In my research group, we are interested in the topics of healthy behavior and actually also effects of aging, and we investigate performance in patients with neurological disorders. That's one of our major focuses. We also have a line of research on the topic of fatigue and fatigability in patients with multiple sclerosis and post-COVID. This I will not be talking about today, perhaps for another time then. So research lines in our lab are tool use and impairments. Typically, limb apraxia is the impairment called when tool use and gestures do not work anymore after, for example, brain damage. We also are interested in affordance-based judgments and reduced performance, for example, due to brain damage or due to aging. We also have a topic that's called rule versus plan-based action selection and effects of load and exertion and other smaller projects on trichotillomania, for example. But the last three I won't be talking about today. The two example research lines from our lab that I'd like to introduce are tool use and impairments and the affordance-based judgments and reduced performance. Both research areas have been inspired quite a bit by problems that we, or also our colleagues in the clinical settings, observed in patients that suffered from a stroke. You may have asked yourself, what is motor cognition? So let me first briefly explain what motor cognitive performance entails more generally. Motor cognition includes, for example, all those mental processes involved in motor imagery or also in simulation. It includes the anticipating, predicting, and interpreting of actions and action outcomes that may pertain to ourselves or also to others. For example, when you look at an action scene such as illustrated here, you as an observer may automatically, or latest now upon my cue, start anticipating, predicting, and interpreting what will happen next. So perhaps there are already any guesses. Of course, you may think the same as I do. The likelihood is high that the next movement will be to put down their teacup. So what you did was imagining how the next step would be. Motor cognition also includes mental processes in which the motor system draws on stored information in order to plan, prepare, and produce our own actions. For example, for motor cognition at work, it's really necessary that we have tool selection processes going on. The planning, preparation, and production of skillful movements are all an important aspect, but it also needs to be learned during childhood development, as we will see in this video. Motor cognition, or for example, the skillful use of tools, becomes observable around approximately the age of 12 to 15 months. And in this video here, the child starts exploring the tool, the goal of the movements, and also the effects of her movements. And partly she already demonstrates some functional movements, but it is clear that her behavior is still far from optimal, I would say. All right. Motor cognitive behavior already is important for development and a core ability for managing activities of daily living. Let's look at the ability of affordance-based judgments, or put differently, deciding about action opportunities, which is called affordances. And currently you may already be seated, but beforehand you searched for a seat and determined to sit down. To put the seating opportunity into action, you probably took your bodily properties and capabilities into account, as well as the properties of your seating option, which you may not have noticed that you did this, but actually you did. You decided that your chair would be a fit. And I'm sure you will agree that small chairs are a better fit to a child, and larger chairs are a better fit for adults. So all these decisions that are going on here are decisions about action opportunities, which is called affordances. And sitting down is an action that appears completely effortless, or at least that's what we think. But the question, can I take a seat, sometimes is not that simple. Such basic movements need to be planned, learned, strengthened, and properties need to be explored to determine the opportunities. And sometimes these action opportunities are offered in a way that we haven't even thought about at all, as you may have seen in this example here. Why should we study motor cognition? Because I think it's such a cool function. Unfortunately, it's also very complex. Here we see a model adapted from Zizek and Kaleska that describes major hubs and networks that are believed to be involved in motor cognitive related processes of all sorts. That involves perception, cognition, planned actions that are translated to motor commands. And what we can see here is that these all are interrelated, and what the assumption here is that they all are dynamic and ongoing. In this model, it's interesting that it basically makes a distinction between action specification and action selection, and we will see this later on also for the case of tool use. Stroke and related brain damage due to bleeding or due to an infarction can impair such aspects of motor cognition as we saw beforehand, like affordance-based judgments or tool use. In many studies, it looks like especially the left hemisphere and especially parietal regions and the regions along the Sylvian fissure here seem very important and are crucial for intact motor cognition. Today, I would like to lead you through two major lines of research that I've been talking about. And those both research areas have, as I said, been inspired by patients that suffered actually from a stroke. Let's take a look. Limb apraxia is a long-known functional disorder. In selecting and using tools, and about a century of research has already been spent on this topic with, of course, ups and downs in its popularity, and currently I would say it is gaining more interest again. Our lab has contributed to the topic by looking at fundamental mechanisms involved in tool use, as well as by putting together a standardized assessment battery, and we piloted a training approach. And next, the assessment has been transferred and is now used in different clinical and research settings. This is something very important that I'd like to show you, because there were a lot of contributors to the topic, a lot of young scientists who really gave their heart into this research. For example, Ilka Buchmann wrote her PhD thesis on the topic. She today works in a rehabilitation clinic, and as an expert, she oftentimes joins me in delivering workshops on the topic of limb apraxia. Lisa Finkel also and Sarah Stoll also contributed as first authors and also co-authors to this field. What is limb apraxia? Georg Goldenberg, he is very known in the area. He defines limb apraxia as a disorder at the interface of cognition and motor control. And since limb apraxia is a very complex syndrome, he suggests that when speaking or writing about limb apraxia, it's like really important to begin with a detailed description of the actual symptoms and also the subcomponents that are being presented by the patients. Amongst a lot of research, Georg Goldenberg also published quite a bit of chapters, and his latest Bible basically on apraxia, which is this book here. And fun fact, he now lives also in Vienna, and we meet up about every 2 to 3 weeks to write a new edition of his book Neuropsychology in German. So limb apraxia is the known syndrome of impaired motor cognition, and limb apraxia can affect action selection and action execution. Components that are involved here are planning, knowledge, and problem solving. Typical tests let the patient imitate movements or postures, or you can also have them pantomime movements, such as saying, "Show me how to drink out of a glass." More seldomly, also real tool use has been evaluated, and we will today take a closer look at that. Typical errors are simply observed, for example, via video rating, and more seldomly, movement kinematics are also analyzed. Limb apraxia has an impact on activities of daily living and actually a negative influence on independence, as you can imagine, when thinking about how people may have to deal with activities of daily living when not knowing how to use objects that we've been previously using every day. A disorder highly correlated with left brain damage. So yeah, it's known for its dominance with respect to the left brain. And this also means that it very frequently goes along with aphasia because the left brain also is dominant for language functions. But it can also occur independently from aphasia. So these are two different constructs to look at. Also, motor areas can be affected by left brain damage, and thus also often hemiparesis or paralysis of the contralateral side of the brain damage, for example, the right arm, because that's contralateral to the left brain, oftentimes also is current in patients with limb apraxia. This doesn't make it easy to assess the impairment. So these issues all need to be taken into account when actually studying the limb apraxia and when developing designs to assess it. So what might not be clear is that limb apraxia is not only something that you can find in patients with stroke, but also in patients, and very frequently, with dementia. It's one of the core features of patients with dementia. You can also see patients with limb apraxia after traumatic brain injury, more seldomly or not as pronounced, but especially when it goes towards rather fine motor problems. It also can be seen in multiple sclerosis patients and in Parkinson patients. And lately, there have been a couple of studies showing that limb apraxia also can occur after schizophrenia, which is not too far-fetched when thinking about it, because schizophrenia frequently goes along with also all sorts of other cognitive disorders. Cognitive models have been mostly developed to describe and explain patient behavior. The originals of the praxis model, that were a lot more complex than the one that I'm showing here, have been published in the 90s approximately by Rothe and Hallman. This here is a really adapted and shorter version. And of course, it's simplified, but it helps to visualize the potential underlying components and mechanisms. For example, for imitating or when producing meaningless gestures, it has been suggested that the gesture is perceived. The visual-spatial relationships between the head and other features of the face are processed, and the accumulated information is integrated with what we called a working memory for action here. And then, of course, the plan is formed, and ideally an exact posture is performed. This here would be an error. Yeah. So if this is the model and the patient would demonstrate something like that, that's an error because the hand is just flipped here. Yeah. For meaningful movements, such as gesturing how to pantomime, for example, using a hot iron, knowledge is activated about the object and its function, and information is accumulated and integrated into the action plan. So all of this goes towards here and goes along the line towards semantics and knowledge and activates this. And this knowledge is then activated, maintained, and integrated into the action plan via working memory mechanisms. And this then goes towards the action output. So that's the very simplified model, at least for the gestural part at the moment. And how do we assess this? In our laboratory, we refined already existing subtests that had been developed by Georg Goldenberg, and we developed additional subtests to provide basically a complete battery for limb apraxia. But this here first are the classic tests, the imitation of, for example, meaningless gestures and the pantomiming of meaningful gestures. And since today we will focus within the topic of limb apraxia on tool use, we will first take a look at pantomiming meaningful gestures. Let's get started with this probably most investigated aspect of limb apraxia, entailing, and that's what I'd like to leave to Lisa in her video to explain it to you.
Die Pantomime ist typischerweise eine Art Bewegungsdarstellung, bei der Handlungen kommuniziert werden, ohne dabei Worte oder Objekte zu verwenden. Auch wenn wir hier kein reales Werkzeug sehen, so wird uns doch deutlich kommuniziert, welches Werkzeug gerade in Gebrauch ist. Bei der pantomimischen Darstellung sehen sowohl die Bewegung als auch der geformte Griff so aus, als würde die Person das Objekt tatsächlich in der Hand halten.
All right. So now you know that the task would be to show how a typical movement looks like, as if the person would hold the object in his or her hand. And next, I also will show you a picture of an object, and I'd like you to show me with your left hand the typical movement you would produce as if you were holding the object in your hand. I will also name the requested action. So please show me how to cut with scissors. I already saw that from my colleague, and he did a good job there. And I'd also like to encourage the others to try it in front of your screen, also if I cannot see you at the moment. But try it out, because we will talk about this in a bit. So here you can see an evaluation form, and you can check, did you fulfill all these criteria when you just showed me how to use these scissors? Did you produce an opening and closing movement? Did you go forward? And what about your fingers? Were these actually angled? Like this, perhaps? Well, perhaps many of you probably produced a body part as object error. So you used your fingers as if these were blades, thereby producing a wrong grip. And I would bet that others observing you would be completely okay and very fast in detecting what you are showing how to cut with scissors. They might even interpret your gesture as a request. They may grab into the drawer and hand you a pair of scissors. So this seems to be something communicative. And there exist some objects that are more prone to body part as object errors than others, also in healthy participants, while cutting with scissors is, for example, such a relatively frequently shown body part as object error. Others, like using an iron or ironing with an iron, is not. Yeah, so here for ironing, typically participants demonstrate how to hold the hot iron in the hand in a correct manner. Also healthy young, also healthy elderly participants. Except that patients do oftentimes also demonstrate body part as objects for those objects that healthy people typically do not demonstrate it. And the next, you will see a reenacted scene. So sometimes we decide to reenact the scenes that we typically see in patients, and this one has been based on a patient video. So the patient with apraxia is asked to please show how to use an iron. And we see an incorrect action, and while the movement looks somewhat like ironing, we saw that the hand was used as if it were the object. There is no space between the hand and the table. And now the question is show me how to use binoculars. And we see that the patient is perplexed and needs several attempts now to then still come to an imperfect solution. And again, it is as if here the body was used as part of the object. All right, so these were a couple of examples. And what we will do next is look at brain damage that may be related to such impaired behavior. So the brain images I will be showing you later will be based on a special type of brain analysis, lesion analysis, which focuses on regions that have been damaged. Depending on where in the brain patients experience the damage, this may then relate to specific functional loss. That's the idea behind it. And it is important to realize that it is not functional MRI, where you see activation maps, which show you all the regions, for example, that are involved in a task. But here instead, we will have a look at lesion maps that where basically for each patient the damage is marked, and this information is then collected from many patients in a group, as you can see here. And then, say, for example, of patients with left hemisphere damage, and then this group data is correlated, put together and correlated with performance in a task. And what comes out of it are lesion maps, and they provide information about the impact of damage, telling us what regions are really important for the performance in that task. So we can make predictions, basically. When a certain region is damaged, there is a high likelihood that a particular behavior is deficient. And when we look at impaired pantomiming and lesion correlates and look at the literature, this is quite all over the place. While results appear stable for impaired imitation of meaningless hand postures, which we got to know in the very beginning, because these are typically and almost always associated with lesions in the left parietal lobe, the literature for the lesion sites associated with impaired pantomime are a little bit more over the place. So different lesion studies report outcomes in rather anterior regions, like those that go further to the front, and ventral regions, and other studies demonstrate associated errors more posterior or dorsal. Yeah. So my question was, what could be the components that influence perhaps whether you may find rather ventral anterior regions or dorsal posterior associations for pantomime of tool use. You may also ask the question yourself, what could be the components that differentiate between these lesion sites? So, yeah, one hypothesis is that there are two major components that contribute to pantomiming that can be differentially affected by brain damage then. Pantomiming has, for example, communicative aspects and perhaps motor cognitive aspects. And the idea was to look whether we could differentiate these. Looking at, for example, categorizations of errors that are rather communicative or that are rather motor cognitive. So errors in movements and errors in grips, we put into the category of motor cognitive errors. And for example, the body part as objects errors, such as using a flat hand like an iron, we put into the communication errors. And indeed, we find distinct lesion maps. So it looks like this could really be the reason, or one reason, for differential results that we've been finding in the literature for pantomime lesion correlates that did not happen to distinguish such error types, but put all the error types into one score. When looking at both, we see either rather anterior ventral lesions or rather posterior dorsal lesions. So if we put them together, we would find a pretty large map. But if we divide them between communication and motor cognition, we basically can divide the type of errors. And this may help to explain why we haven't been that sure in the literature about related aspects yet. All right. Looking at the next step, handling real objects instead of gesturing, we similarly differentiate between actions with novel tools, so things that we didn't know beforehand, and actions with familiar tools, with known tools and objects. And again, here we have these routes for with visual input about these novel objects, where the task would be to select one of the three tools here to put into work at the cylinder here and lift the cylinder out of the socket, and do this in the safest way as possible. So for this, you would look at the visual spatial relationships between, for example, the objects and the tools and the recipient object here. And then you would integrate all the information that you perhaps also collect along the way into a working memory for actions, and then realize the action plan via the action output. For familiar tools, this is a little bit perhaps quicker because you already have a concept of how to do it. Yeah, so for getting, for example, the egg out of the pan, you probably would not be using the bottle opener, but you probably would be using the spatula here because you know this, yeah? So what you do is you activate semantics and knowledge, and then you basically introduce this into your action plan, and then action output is happening. So that's actually the very simplified idea of how it may work. But it helps to distinguish between the components and also between the type of tasks that we apply for assessing limb apraxia. So these assessments were also included in the diagnostic instrument for limb apraxia. And so exactly these tests, people are basically given 3 different tools, and they have to select first the one tool that is best suitable to apply to the recipient object. And they have to do the same thing for the novel tools. And again, I'd like to show you the reenacted scene here from a patient. So what typically happens is that most patients actually demonstrate disturbances in both, in selecting the tool and in applying it, but it can actually also be impacted separately. I still remember seeing my very first patient during my PhD with limb apraxia, and I was pretty astonished that the things and actions that seemed so simple to me didn't work. And actually also one of my first patients was a cook, a hobby cook, and she didn't know how to, for example, use the spatula, which was pretty devastating. All right, so you have a picture now what happens there. And similarly, of course, we can see this in novel tool use, but for novel tool use, you have to use a little bit a different component. You cannot rely on familiar knowledge, semantics, but you need to use mechanical problem solving to safely lift the cylinder out of the socket. And of course, the visual spatial relationships should be appropriate here. All right, so also here we see that the selection as well as the application can be affected in patients with apraxia. We looked at a group of left brain damage patients and right brain damage patients and controls using their left hand and controls using their right hand. We did that because, for example, left brain damage patients frequently can only use their left hand due to the hemiparesis that they have in their right side. And for right brain damage patients, it frequently is the other way around. So we also had a control group using only their right hand. That also means that you need to have these groups tested in exactly this way when you are collecting normative data. Because you would like to see where your patient is within that normative set of data, then you of course need to compare it to a control or healthy person that has had similar conditions, using only one hand and using, for example, only the non-dominant hand. So let's take a look at the behavior. We see here that when looking, for example, at the controls in the left hand and left brain damage patients, that the left brain damage patients are significantly worse compared to their controls. And also they have a lot more variance compared to any other participants in selecting familiar tools. It's very similar for the novel tools, although in general, it looks like performance is a bit more variable here. But this may be because this task itself seems a bit more difficult also for healthy adults. Since here, you have to also include mechanical problem solving and reasoning. For executing the movements, we clearly see here that this patient group with left brain damage has a disadvantage. And so patients show a lot of errors here. And it's relatively similar, but not as extremely as for familiar tool use here in the novel tool use section. So especially left brain damage patients seem to produce errors when choosing and when using tools. And importantly, there are some individuals with left brain damage that demonstrate efficient behavior only for either tool use or for tool selection. So for different processes that can be affected selectively. And here we see the lesion data. We also did lesion maps for these patients to see what kind of areas might be related to impaired novel tool use or to impaired familiar tool use. And of course, we took a look also what overlap there is. And for novel tools, it's depicted in blue, and familiar tools, it's depicted in red. On the left-hand side, we see tool selection, and on the right-hand side, we see movement production. And as you might realize, there seems to be a distinction between the novel tools and the familiar tools. And this is a bit more expressed in tool selection compared to movement production, where there seems to be a lot more overlap, especially here in inferior frontal and in inferior parietal regions. Whereas for selection, there seems to be a distinction between selecting the novel tools versus selecting familiar tools. And this is pretty interesting because we know from the regions here, from these ventral regions, that these are typically associated with knowledge, with object identification, whereas these regions here are, for example, typically associated with selection, with rules, for example, as we may imagine, rules how to use novel tools, rules about mechanics, and also more about the motor processes that might be involved. Okay, so coming from there have been also reports that some patients even have a lack of insight into apraxic deficits, meaning they may not realize that their tool use behavior is impacted. And as you can imagine, missing insight into the impairment could impact the way patients act within their environment. Just imagine what might happen when they come home not realizing what they are able to do or what they are not able to do. We therefore developed a questionnaire to assess the patient's self-evaluation, and we had a team member rate the patient's performance based on their observations from all the tests that we collected. And we found indeed that there are some individuals with tool use apraxia who demonstrate a discrepancy between their self-evaluation and the evaluation by our team member, which points towards a lack of insight. This brings us to the next step here. How should we train these patients? And there have already been a couple of training approaches that seem quite successful, using, for example, a lot of practicing actions that are important for a patient. And we basically adapted this approach because we thought what is successful we could already implement, and we put something on top of it, which is a feedback procedure. So what we did is, for example, have a bunch of tasks, and the patients were able or allowed to choose those tasks that are on the one side impaired, of course, but on the other side that they really would like to learn. And for example, one task is to mail a letter. Yeah. So they're, for example, given a picture with a goal, which means the letter to mail. And then they're asked, please prepare the letter to mail. And for that, they are exposed to a large drawer or cupboard with drawers, and they are asked to select the material out of the drawer. So here we already include the selection of tools and objects. And then patients are asked to fulfill the task in the picture and afterwards also to clean up. We, of course, help them because we would not like them to produce too many errors, because we know that, for example, procedural learning seems to be pretty intact. At least a few studies showed or had some hints towards that procedural learning appears okay. So when procedures are learned in an erroneous way, this doesn't make much sense. That's why we, of course, took a look that there was also errorless learning and stop erroneous behavior right away. We also used shaping to make it a little bit easier also for the patients to get started and to stay motivated. So stepwise with pictures, for example, depicting sub-steps, please choose first the letter, then choose the stamp, then for the letter and the envelope, how should you be folding it so that it fits into there. So for all these different sub-steps, we had pictures made. And what was really important is that we added feedback on that performance. So patients were asked to first evaluate themselves. How did you perform in the test? What do you think? And did you have like no difficulties, or wasn't it possible at all? And then the therapist gave his or her rating on top of this, and it was basically compared and discussed with each other. And one really important thing here is not to only point out the weaknesses, but also to point out what the patient already did very well. So also look at the resources and the strengths. So that the patients stay also motivated and get that feedback as well. Yeah, so this you can actually do with quite a lot of tasks, and this also has been applied in a rehabilitation setting in a more flexible way already, where the colleague of mine, Dr. Buchmann, for example, has tasks like brushing teeth, and where the patients have pictures on their mirrors in for the morning, for example, how to brush their teeth and what type of objects and tools they need for that, and what the steps are there to remind them, and then reduce these cues along the rehabilitation so that they have more independence in basically performing these activities of daily living. We looked at 2 cases here where we applied the naturalistic action training. So it's really small. And of course, it would need a larger group and a randomized controlled trial and so on, like the typical steps to evaluate this training. But this was one small pilot study with this approach, and it looked pretty good. What we did were 15 sessions of a training of 4 to 6 tasks out of 80 naturalistic action tasks. 4 to 6 of those tasks that didn't work out well for the patient and which he or she did really want to train. And here we see the results of that. That's baseline average, so in the beginning where they started, and this is post-training for the train tasks. And we see for the train tasks, there's like really a huge performance increase from example 30 to 50% here, or from 40 to even 70%. But, and what is important is that not only the train tasks, and that's relatively new because many studies showed that training them mostly stays for the trained tasks, but does not have any effects on untrained tasks, no transfer. And here we could demonstrate that there is some transfer also to untrained tasks, which also improved. And that means for the familiar tools test, as we got to know it beforehand, but also for a test that I did not show you yet, but that we also include in the diagnostic instrument of limb apraxia, which is a naturalistic action task, making breakfast, yeah, which is an adapted version of Buchsbaum and Schwarz. Yeah, so this was good news on this side, but of course this still needs to be broadened and evaluated in a much deeper way. What's the outlook here? Well, one is, how does healthy aging affect the use of digital tools? Yeah, so digital tool use is a topic that we'd like to target next. And how does brain damage affect digital tool use? And what motor cognitive components are involved in using digital tools? And that's actually a project that we'd really like to collaborate on with our colleague Gregory Kroliszek. In the next part, I will tell you a little bit more about affordance-based judgments, about the second research line that I mentioned in the beginning, and reduce performance there. And that's, of course, a much younger research line. It's not as elaborated as tool use and impairments in limb apraxia, but here we just got really started by studying the fundamental mechanisms involved in affordance judgments, as well as by starting to develop first approaches to assess affordance judgments in patients. And we started developing a first training approach for healthy young and older adults. And there's still really plenty to do to get this as far as our achievements for tool use disorders. But still, I would like to show you our first efforts here in studying affordance judgments, because it's also a way of working what we develop at the university to transform and translate it for useful approaches in clinical settings. And again, here I'd like to show you the young researchers who have really significantly contributed to the studies. Lisa Finkel received her outstanding doctoral degree based on her work on this topic. And more recently, Milena Girls and Isabel Bauer followed and started contributing to the field. And for our latest work, we actually collaborated with really supportive colleagues in the Department of Computer and Information Science, and worked on a topic that included virtual reality here. Yeah. Typically, healthy young adults really perform quite well when judging whether actions are possible. For example, whether the cup in front of you is within reach. You typically do this quite well. But sometimes such decisions can go really terribly wrong, and in some instances we even read about such things in the newspaper. For example, when the fire department has to rescue someone's hand out of a letterbox. Or we hear about this topic when insurance companies try to warn about risky decisions and describe heightened numbers of, for example, elderly men falling from ladders. The tricky thing is how to come up with experiments that can actually measure such faulty decisions. And for this, I'd like to show you two exemplary tasks that we developed in our laboratory in order to investigate the matter. And I'd like to show you a video for this, because that makes it a bit easier.
One of our newer projects focuses on decision-making in motor cognition. How do we decide whether an action is at all possible? Is this object within reach? Can I stick my hand into this opening? There is some evidence that the way we judge changes when we grow older, and that stroke can affect our judgment significantly.
All right, I hope you got a first impression here. And what we asked the machine shop to do is build the setup for us. Unfortunately, we were fortunate that the University of Konstanz had a nice machine shop that did this. And we will take a look at the apparatus and the aperture apparatus that accompanied us already for quite a while now. Actually, I started working with such an apparatus in the United States already when working with Scott Frey. And perhaps my colleague Gregory Korczak still remembers this. Yeah, so participants here receive different sized openings and decide whether their hand would fit into the opening, yes or no, and they are pressing buttons here. They're also wearing goggles which can open and close, and which basically can, with which we basically can control how long they can see the opening here. So they only see the opening in a steady phase, and you may want to see it briefly again. So this was a no answer. Now the goggles open and close again. Open, close. All right, so that was the procedure. And we looked at typical variables such as accuracy, so how well do they do their job when answering yes or no, but we also analyzed detection variables such as perceptual sensitivity and response tendency. I'm not going to go deeper into this, but the important part is that perceptual sensitivity is represented by the variable d prime, and that means a higher value indicates better performance, so higher the better. And what it means is that a subject would be able to discriminate a fit from a non-fit. Yeah, and it tells us basically whether our participants or patients can distinguish actions that are possible from those that are not possible. The criterion C is the measure for judgment tendencies. These can, of course, be liberal, so people say yes too often, for example, or conservative, meaning that people say no more often. No, my hand doesn't fit in there. And what we also see is that there is 0 means neutral. Basically, you could interpret it as being perfect, so that you do not have any kind of criterion, but whether that's so perfect, we have to discuss, because actually it looks like patients with left brain damage show this behavior a lot more often compared to healthy controls, looking like a loss of a criterion, and we will look at this later on. So first question that we'd like to answer is aging associated with changes in perceiving action opportunities, and is it trainable? And we looked at these two age groups here, younger adults and older adults, and compared them. They appear to have a similar perceptual sensitivity in this task, but their criterion differs. And we take a look at the criterion, their judgment tendency, here. So the majority of gray dots, which represent the older adults, the dark gray dots, are in the conservative section. And the young adults, they are more in the liberal section. Yeah, so these are the lighter gray dots here. And also, it looks like, especially when being more conservatively, then that goes along with higher risk perception, like perceiving actions as being more risky, yeah, which fits quite well with the tendency to judge more conservatively and say, no, I cannot do this. Yeah. And it looks like for the aperture task, at least, this seems to be more conservative. We will have some more data on this by the end of this year, demonstrating that this conservative criterion doesn't seem to apply to all tasks. It looks like some tasks are more liberally judged, and some tasks are more conservatively judged by elderly, but in any case, it looks like they're more extreme compared to young adults in their behavior. But for the aperture task, we already took a look whether it's trainable. And for the training, participants were allowed to actually try and fit their hand into the opening. And they were asked to try every time when they see the opening. Even when they would think that it doesn't fit, yeah, so that they really get the feedback in the moment. Okay, so in the back there is a panel, and the panel is connected to a sensor, and that sensor can trigger a tone, basically giving feedback on whether the back panel has been touched or not, and whether that touch was successful or not. So training included acoustic, haptic, and actually also visual feedback. Yeah, at the beginning, the young and the older group are at a similar starting level here, as we can see, yeah, for perceptual sensitivity. And in younger adults, the Friedman test results revealed a significant main effect of training. And we see a similar tendency here for older adults as well. But that doesn't reach significance, basically. what we were able to see were generally reduced variability and actually improved values in perceptual sensitivity in training especially, and especially for the younger adults. And also here we saw an improvement, but unfortunately not significantly. So looks like perhaps older adults may need a little bit more training to consolidate it in a better way. So that's our hypothesis at the moment, why it might not have reached significance here. On the other hand, we see for judgment tendencies that, of course, the older adults were a lot more conservative. Friedman test results revealed an effect of training in older adults only for their judgment tendency. So their judgment tendency went towards an ideal criterion here after training. So they were not as conservative anymore. And this remained also post-training. And in follow-up, it got a little lost, but still was better than beforehand. Yeah, brain damage can affect affordance judgments, and especially patients with right brain damage demonstrate reduced performance in perceptual sensitivity. That's the results of a study from the US still. And we also found that left brain damage patients were really kind of perfect when they were neither liberal nor conservative as compared to their control subjects. And this could be interpreted basically as a loss of criterion. We already heard that there might be patients who may have a loss of or affected ventral regions, and these might actually cause a loss of the criterion and cause a loss of getting knowledge or activating knowledge that has been created over the past decades, perhaps. And with this hypothesis in mind, we of course took a look at the lesion correlates. And as we might imagine, for perceptual sensitivity and impaired behavior therein, we would rather expect more dorsal regions, and perhaps in the right and as well as in the left brain. And for the loss criterion, which we only found in left brain damaged patients, we would expect a little bit more ventral regions. And actually, this is what we found, except that it wasn't that ventral here, but along the Sylvian fissure here, and especially, here also along the insula. Yeah, so this is basically what we found, which is really nicely in line with our hypothesis. All right. The problem remains that it is almost impossible to have standardized tests using such huge physical apparatuses as we developed and tested them. To put these into clinics, that's almost impossible. It's even a challenge for universities to provide you with space, including such huge apparatuses. And in order to look at performance in different tasks, let's say 20 different tasks, we definitely need another way to implement the assessment and the training of affordance judgments.
We recently also started to evaluate the use of virtual reality for our work. This raising technique may provide a way to facilitate the administration of tests and trainings.
So what we did is basically include virtual reality in this, and this is how it looks like, yeah, from virtual to physical environments when judging action opportunities. And the question was, are diagnostics really transferable, and are training transferable between virtual and real environments? Now here we do have the real physical environment as we got to know it until now, and this here is a virtual environment. This here basically is the Oculus Rift goggles, and what we see up here is what the participant sees within the goggles. That's a picture basically that they see. It seems as if they would be sitting really in front of it, and it moves with the body. Okay, and so what we did is we had a research plan, of course, and we provided participant with a familiarization block and then test their performance in the physical and virtual environment. Yeah, so this means physical environment, virtual environment. We had them introduced to both blocks and then had experimental trials to see how well they are doing. And to see whether they are really equivalent, we used equivalence testing and looked at the difference between the virtual environment and the physical environment. And that needs to actually fall within equivalence bounds. These, for example, are equivalence bounds that we calculated, and the difference between the means between virtual environment and physical environments needed to be within those bounds, which is the case here. And for accuracy, that means that accuracy performance has been on a similar level between the virtual environment and the physical environment. So that was a check. However, it gets a little bit more inconclusive when looking at perceptual sensitivity, because here we see that the difference also goes beyond the boundary here. And here, the boundaries would be this one here, these two here, and it is definitely outside of those boundaries. So judgment tendency differs obviously between virtual environment and physical environment. It's not on an equivalent level. Yeah, so what we take a look at in the second part is whether this one, which was equivalent and could be compared between virtual and physical environment, would be trainable. So we gave a training in the virtual environment and looked whether experimental trials in the physical environment improved as well, or whether virtual and experimental trials in the virtual environment improved. And of course, we had the sequence counterbalance. So there was one group starting the other way around, but still training was only given in the virtual environment here. And what we found is basically on a descriptive level, participants improved in judgment accuracy in both physical environment and virtual environment from pre-training to post-training. However, the statistical pre-post comparisons revealed that participants' performance only improved significantly within the VE. Yeah, so within the virtual environment, they were pretty good and improved significantly also post-training. In the physical environment, it looks like they improved, but it's not significant, unfortunately. And the question remains now, of course, why this is the case, and perhaps it may need longer training in the virtual environment so that it can transfer to the physical environment. Perhaps there may also be other variables as the ones that we've seen that should be more equivalent to be able to have a more complete and more holistic training there, and which might be necessary actually to have it on an equivalent level here. All right. So today I gave you a brief look into our two research lines in our lab on tool use and impairments and in affordance-based judgments and reduced performance. And here I'll give you a summary. We found that after brain damage, tool selection as well as tool application can be impaired both while handling novel or also familiar tools. And in neurological patient samples, we found strong impacts after left hemisphere stroke and in patients with dementia. Lesion data of a large patient group showed distinguishable lesion sites being associated with deficiencies in handling novel versus familiar tools, and especially this distinction was clear during selecting the tools. Then the VATA-NAT was a questionnaire that revealed that some individuals really show also an impaired insight in their difficulties with using tools and related multi-step naturalistic actions. The naturalistic action training as a therapy approach considers the multiple levels of difficulties, and it shows improved behavior in a case study. The next step, of course, will be to evaluate digital tool use performance and see whether we can develop a training to improve the patient behavior there as well. Looking at affordance-based judgments, we saw that brain damage can affect them, and especially right brain damage affects perceptual sensitivity, and left brain damage appears to affect a loss of the criterion and judgment tendency. And so patients do not express the judgment tendency. Lesion data suggests that there are differential sites to be associated with impaired perceptual sensitivity and with altered judgment tendencies. Affordance judgments are trainable in young and older adults, so that's really good news. And we need to have a look still whether that's also the case for patients. And affordance judgments can be tested and trained in virtual environments, but that's a big but. That depends on the behavior variable. Equivalence was there for accuracy, but for detection variables such as perceptual sensitivity or judgment tendency, that's not certain yet, and we need to find out why that's the case. And the next step will be to evaluate the trainability of affordance judgments in patients with brain damage. And of course, as we already saw, this is a project that still is at the very beginning, and we hope to further contribute to the field in the upcoming years. So, George Bernard Shaw once said, if you have an apple and I have an apple and we exchange these apples, then you and I will still each have one apple. But if you have an idea and I have an idea and we exchange these ideas, then each of us will have 2 ideas. And for me, this quote really fits to the collaborative efforts and our work at the intersection of science and clinic. And by the way, a less fun fact at this point is that Bernard Shaw really died at the age of 94 of kidney failure that ironically appeared to be caused by injuries because he fell while pruning a tree in his garden on a ladder. So perhaps this happened because of misperceiving action opportunities at older age. And in general, I think the whole is something besides the parts. And I think it's, for us, it's really been a great experience to work, to link the work at the university with the work in clinical settings. Thank you for your attention. And of course, these amazing people for their hard work. I'm happy to take questions.